Now let's hop on to the long-term ones. And here you go. You have that graph shown again. Look at the red and the green lines, okay? And this is basically to show you now the way the green line has been plotted in this graph. So any increases in mean arterial pressure over longer duration of time will have uh, these long-term mechanisms come into play, which really keep the blood flow to the minimum, and increases will be shunned, even though you are really increasing the feeding pressure, the mean arterial pressure. So how come this is achieved? Clearly, acute mechanisms which we have discussed up till now do provide you immunity, but to a certain point. And then if you keep on increasing blood pressure, the blood flow will start increasing, which is catastrophic really. But Alhamdulillah, what happens in long-term mechanisms? What happens is uh, the the curve is flattened even during the long term. What could possibly happen in the long term, which gets us this very marvelous result? Well, a couple of things actually. Number one is angiogenesis. Angiogenesis, as the name indicates, is formation of new vessels. Okay, you see that this is yes, it's a Guyton diagram, and this is a skeletal muscle of a rat, I believe, and this is a normal picture of the muscle, and these white beads are the blood vessels, and then they stimulated the muscle at a specific rate over months, and see how the white beads have increased. So this is angiogenesis. Also to note is the size of the muscle fibers has actually decreased. So there's decrease of diameter of the muscle fiber, increase angiogenesis. Basically, the surface area ratio of vessel to its supplying mass is really improved for better circulation and to make it more leaner and meaner, as they say in slang. And how is this vascularity changed? A key role is oxygen. Then there are various endothelial derived growth factors. VEGF is one, uh, fibroblast growth factor, angiogenin. All of this you can read in your books. They are pro angiogenesis. And then there is uh, this is an important principle that vascularity basically is determined by uh, the number of times the maximum blood flow had to be achieved to address the metabolic profile of the tissue, okay, not the average. So a muscle of a bodybuilder, uh, it really peaked in its blood flow requirement, in its metabolic requirements during one of his exercise routines. Okay, so now the body will calculate that okay, this guy, uh, his muscles have this upper end of this metabolic requirement of the muscle. So the vascularity will then increase in those muscles, keeping in view that peak and not his average during the day when he would go about his normal business. Okay, this is an important point. Uh, there are limitations in the sense that the new vessels, I beg your pardon, the new vessels they don't function as the normal quote unquote genuine vessels. They generally are dormant, vasoconstricted. Then only they may not give you a lot of backup during rest. However, when the body goes into an exercise or increased metabolic profile, then these new vessels come into play. They dilate and they provide you the backup. And the word is backup really. They together with the existing vasculature, they fill up the gaps for blood flow. Here I would like to reiterate the role of oxygen that is played in angiogenesis. It's a very interesting thing in neonates who are born prematurely. They have to be kept under artificial oxygen when they're born, right? So what has been observed, and it's very interesting, and Guyton details it, is during that time, uh, during which they have to be given supplemental oxygen, their vessels, the growth of their vessels really drops, okay? Because you are supplying uh, adequate oxygen. So it really, for angiogenesis, and especially this is a fetus now, so everything needs to first develop. So if you supply it with uh, enough or a bit more of oxygen, the body will not feel the need for making new vessels. How's that? So this little guy, his vessels will stop growing if there is too much oxygen given over a longer period of time. So if Allah forbid he is in distress, respiratory distress, and you have to keep him there is a cost that you incur in terms of the angiogenesis. That in his case is the original angiogenesis, which needs to take place part of the normal development, right? So much so that sometimes what happens uh, is when you take them out of this artificial oxygen environment, there is an explosion of angiogenesis. You would think that's a good thing, right? Not if you are sitting in the eye. In the eye, the retinal vessels really start to sprout to the extent that they even come onto the cornea, causing blindness. Okay, causing blindness. Now, this is just to signify the role oxygen plays, lack of oxygen plays. So, coming back to normal life, if you if you start to exercise, the concerned muscles with the exercise will have increased oxygen demand because the existing oxygen profile is not enough now. This increased oxygen demand will dictate angiogenesis. This is the concept. Okay. Formation of collaterals, as the name indicates. If there is a blockage of a vessel, collaterals would develop which bypass the blockage. These new vessels can form within minutes to hours, and they continue to grow and multiply in the coming weeks. These are collaterals, not as good as the main artery, but if they're allowed to grow and multiply enough, they can provide a decent enough backup to the tissue, such that no great problem or damage happens by blocking or semi blocking of the feeding vessel. This whole thing come to focus in coronary artery disease, in which the atherosclerotic plaque now has pouched into the lumen and has actually blocked it. So if there's a coronary and it's blocked, you can imagine what would happen. And check this out. It's a very interesting detail. In most of us, alhamdulillah, what happens is during our time, we do have this atherosclerosis going on since our teens. Okay. In your case, you are a teenager, probably. I'm talking about myself here. So this atherosclerosis has been going on for a while. And depending on your diet, etc., the rate of atherosclerosis varies. Now, generally speaking, people who don't end up having a heart attack or any significant heart event, what happens is there is atherosclerosis. There are thrombi that form, which semi or not completely occlude, but sort of half occlude a vessel, affecting the coronary blood flow to the to wherever whichever area of myocardium they're supplying, and this causes decrease in oxygen tension and all that, and causes the sprouting of collaterals. So while the guy is going through his life, normal routine, uh, he or she does not even notice that collaterals are actually sprouting out, bypassing uh, these blockages all the time. Okay, and they connect the pre-block part of the artery with the post-block part of the artery, quite literally bypassing the blockage, so that the blood flow to the to the wherever this artery was going is not compromised. So this is very interesting. Collaterals are formed in normal people, in all the people actually. If you exercise routinely, guess what? You increase these collaterals. That's why people say people are asked to exercise routinely. Okay. The more exercise they do, even if they were to do a 30-minute brisk walk um, every day, this person would have enough collaterals that if he behaves in his diet, does not smoke, and doesn't have a very wicked family history for heart disease, he may never have cardiac symptoms, even though there will be thrombi, there will be occlusions in his coronaries, but there will be enough collaterals that this guy will be okay. Okay. Okay, so one of the final points now is vascular remodeling. So we have talked about angiogenesis, which is the formation of new vessels. We then talked about collaterals, which is the formation of new vessels, which would bypass a blocked vessel. Okay. Now now we can talk about what if there are chronic changes in blood flow, blood pressure, or both. Okay, let me just clarify this here. So when I say increased blood flow, there's a problem in increased blood flow. I'm talking about the volume, okay? And when I'm saying increased blood pressure only without the flow component, I'm saying that there is only a problem with pressure. So let me further give you a comment or two to clarify. In hypertensives, what essentially happens in most hypertensives is there's a chronic increase in blood pressure. Okay. Now, if this guy is a new hypertensive, they will know there won't be much change in the volume of blood. You will have the same volume of blood, but the arteries would be stiffer than a younger chap. So they won't expand to accommodate for this increase in pressure. When they become stiffer, the same cardiac output would now cause increase in blood pressure. If you remember the formula for blood pressure is cardiac output into total peripheral resistance. So cardiac output being constant, but the wall has become stiffer, so the resistance will be more, resulting in increased blood pressure. Yes. So there are scenarios where you would have chronically increased blood pressure. Then you have scenarios where your kidneys, as a result of this hypertension, will start to retain fluid. You have decreased kidney blood flow for reasons which we'll discuss in hypertension. And the kidney will start to retain more fluid. It shouldn't, but it does because that's how it's designed. And you have now two issues. You have stiffer arteries and you have more blood volume. So double the trouble for this chap. And let's see how uh, this whole thing now fits into our long-term regulation of local blood flow. So there are four mechanisms mentioned in your textbook. Okay. First scenario is eutrophic remodeling, which is depicted here very nicely actually. So this is a normal blood vessel, no problems in pressure or flow. And now what happens is that there is increase in pressure. How will how may this vessel respond? One of the ways is inward eutrophic remodeling, which basically is it uh, it rearranges its visceral muscles. First, it vasoconstricts, of course. We've discussed this on the myogenic mechanism. And over chronic, if that event of increased pressure was not addressed, and now it has become chronic, i.e., increased blood pressure all the time, then those vessels which constricted, their vessel wall, the visceral smooth muscle in their wall, uh, readjusts. And now this is a very interesting word, readjusts. It readjusts in a way to accommodate or absorb this increase in pressure, but still keeping the same cross-sectional area. I was thinking of an example for this to explain it to you. It's like, a new sock. There is a brand new sock that you've just bought, okay, as compared to your old sock or your dad's sock, okay, which he has worn out, or because of maybe he has a bigger foot, it has different dimensions. Your new sock, you put it on, okay. What does the sock do? Does the sock change its internal diameter? It does, but how does it do it? It basically adapts to the shape of your foot by readjusting its balls, doesn't it? You have never paid attention to the sock, did you? If you did, you would understand. A new sock, when you put your foot in it, it will readjust by readjusting the small elastic components in its balls so that it takes the shape of your foot. Okay, your foot will not change its shape, of course. The sock will have to oblige, and it does that by changing its uh, uh, shape, the shape of the wall, the volume being the same. Okay, it's the closest, guys. It's the closest example that I could think of, while not being explained, trying to not having to explain it with my hands, or with a blackboard. This is the best, I think, the example. Inward eutrophic remodeling is in small vessels which constricted, trying to resist the chronic change in blood pressure with no cross-sectional area by readjusting the smooth muscle in the wall so that it absorbs the blood pressure. So that's one way uh, things can happen which controls local blood flow. The second one is an explanation of the large vessels which don't constrict. Again, this happens, and vasoconstriction happens in the small muscles, small vessels, I beg your pardon. The larger ones, they don't vasoconstrict. Instead, what happens in them is a phenomena called hypertrophic remodeling, which is depicted here. So basically what happens is the visceral smooth muscles, they proliferate in number and they enlarge in size. Okay. So they resist the damaging effect of increased blood pressure over a long period of time. This increases their thickness and the total surface area. Okay. And this, by the way, also increases their stiffness. So this is that cost that you need to understand. You have chronic hypertension. Hypertrophic remodeling will absorb that hypertension, will absorb that chronic raised blood pressure all the time by literally increasing the thickness of large arteries so that they don't burst, or they don't damage easily by this constant increase in pressure. However, by adding to their thickness, they also become stiff. So the diastolic pressure will drop and the systolic pressure will increase, basically saying the blood pressure will further increase, further worsening the hypertension. Um Remember, these are not, these are just remedial measures. These are not therapeutic in the sense that they don't bring the whole thing down to dot. This is the normal vessel, not this, not this, this. So we need to keep the vessel as much as possible in this scenario. If we don't properly control our food, or we don't exercise, or we do this silly thing called smoking, then you will end up having this, which will, okay, hold the fort for a while, but this in itself is a problem. This makes the whole thing stiff. Okay. Third point is outward remodeling. So when this whole system is exposed to even further chronic increases in blood flow, so the kidneys keep on adding volume to the blood. Okay, what happens is this will then expand the the lumen of these large vessels will expand with little change in the wall of the vessel, in the wall of the vessel. And you have a total increase in cross-sectional area. Now, look at the cross-sectional area here, here, and then look at the cross-section here. There's obviously a greater cross-sectional area through which blood can flow. This again will uh, uh, contribute to decreasing the blood pressure, that this increased uh, blood flow will obviously exert on the walls. By enlarging this whole lumen, you're trying to dissipate that increased pressure that comes in with that increased blood flow, okay, by increasing the cross-sectional area. And lastly, outward hypertrophic remodeling. This was outward remodeling. This is outward hypertrophic remodeling. This happens when the guy is not listening to the doctor. He is his diet is outrageous. Salt intake is outrageous. Meat and all the fried things and this, that, the other. He's not exercising. He's not quitting smoking. He's sedentary. He just sits in his office and works and does not move around much. So then what happens is the kidneys keep on adding the fluid, which increases his blood flow, the volume of it, and his blood pressure also rises because the arteries are becoming stiffer and stiffer. In this case, the lumen does enlarge, but to a lesser extent, the wall thickness really enlarges. The whole thing goes outwards. The total cross-sectional area does increase a lot, but at a cost which we have already discussed. So these are vascular remodeling, the four scenarios where the vessels themselves remodel. The first two, angiogenesis and collaterals, they are examples where the vessels multiply in numbers. This is a good depiction of how the existing vessels, they change their shape. This happens mainly in big and smaller arteries, while the number angiogenesis and collaterals, they occur in the smaller vessels and meta-arterioles and capillaries and so on.